So that means that men have a role to play in preventing cervical cancer.
Yes, they have a very, very significant role to play in preventing cervical cancer. So what that means is that, all right, you want to say something?
No, go on, sir.
The important role men can play is in the aspect of encouraging vaccination and screening. You know, in most of the homes in Nigeria, men play a key role. The key role they play is that they own the financial power. This financial power, they can put it into use by encouraging their partners, that's the women, to go for screening, or to encourage their children to pay for vaccines that they are going to receive. That's one aspect. Another aspect is that they can play a role in reducing HPV transmission. That's the transmission of the HPV virus. Because men can be carriers. Remember, I talked about men that are uncircumcised. Those ones harbor the viruses in their prepuce, and then they can transmit it during coitus. But another thing is that for men to help in the breaking the transmission, it is advised that if, the use of condom by men is very important too. It helps in breaking the transmission, cycle. And then those who have not been circumcised, where the context permit, they can undergo voluntary circumcision in order to avoid transmission by the males. So there's another aspect that the men can play too. That aspect is in the area of advocacy and education. So, when men are involved in educating their communities, they should be seen to debunk certain myths associated with cervical cancer. Let them be seen to be creating awareness about the danger of the cancer, the transmission, what it causes, and then how it is being cared for. That's the patient who is being infected or will develop the cancer. Where will you find help? It's very important. So one aspect that the men can do to help in the care of people who have the cancer or to break the transmission is to help with primary decision that involves cultural, traditional, or religious beliefs. There are people that think that when you have cancer, you are not supposed to go to the hospital. You are not supposed to take certain injections. All those all beliefs. Some beliefs around this. So enlightenment to, break down this. In order to break cultural, traditional, and religious barriers is very important. Men should be seen to participate in that so that, it can reduce the transmission, of cervical cancer. The viruses that will cause cervical cancer. So it's very important we create such an enlightenment. So men play a role in that, so that transmission and development of cervical cancer is reduced. Thank you.
Thank you, sir, for your input. I think that is very, very insightful and super important. Men stepping into the light when it comes to cancer will really change the narrative, because we know in public health about the three delays model. And the very first one is delay in deciding to seek appropriate medical care. And like you said, a lot of it weighs on the husband, or rather the male, because they have the financial capacity of the family. And even not so, for women that do decide to seek medical help, I have had, or I have seen patients who come in with maybe breast cancer, cervical cancer, and at the end we witness the men leaving them, like before they even leave the hospital bed, as in divorcing them or leaving them. So overall, it adds to the stigma surrounding cancer that affects women, and affects the mental health of women, and this can influence their decision to even seek help or even admit that yes, okay, they have this type of cancer, and they're willing to go to the hospital to get checked for it. So thank you very much for that. The next question is, uh, from a pathological point of view, is cervical cancer considered a preventable disease?
Yes, in fact, many people believe it is a sexually transmitted disease. So sexually transmitted because it has a biological factor that is involved in the causation. And then that biological factor we're talking about is the human papilloma virus. So the human papilloma virus, infects the human and get integrated into the cell. And the next thing is for the cell to be transformed into a cancer cell. And then it keeps proliferating until, uh, you know, the cancer continue to increase in size also. So, but with early detection, you know, it is being treated, well. But when there's a delay in the detection, that's when the problem comes up, and then the patient develop a lot of complications. So it is a sexually transmitted disease. So if you can break the barrier in the transmission, so women or men may not develop cancer from the uh, human papilloma virus. Cervical cancer will not be developed. Just like we mentioned those factors, we take them one by one. If there's a behavioral change, especially when there's faithfulness and then enlightenment and then, the use of vaccines. So these are categorized under primary prevention. So you educate the people, they know how the cancer, comes about, how it is transmitted. How the virus is transmitted. And then, you enlighten the people around about that. And then in addition, those who require the vaccine, you give them the vaccine. And then the community develops a herd immunity, the immunity that prevents, people from getting infected by the virus. So once you are protected, you may not develop the cervical cancers through, lifestyle modification. The men must be faithful, women must be faithful. And then if the men must be unfaithful, they must use condom. so that they should not get the virus and transmit to another person, or they don't give to another person. So it's very important that I will look at it like that. So it's a preventable cancer once we observe this primary prevention. Thank you.
Thank you very much, Dr. Nicholas Papmi. I believe we'll circle back to you. So we're going to proceed to our next section. I'm introducing Dr. Hannatu Favor Kachuro, our obstetrician and gynecologist. She's a global health professional with over 10 years of academic, clinical, and public health experience. She's a fellow of the Medical College of Obstetrics and Gynecology, and she holds a master's in global health policy from the University of Edinburgh. Dr. Hannatu, are you with us?
Good evening, everyone. Good evening, Dr. Nabila. Thanks for having me here
Good evening, Dr. Hannatu. Thank you for having us. We've wasted a lot of time, so we're going to go straight into the question and answer session. So we'd like to know from your expertise and your specialty, what are the early symptoms that women should never ignore regarding cervical cancer?
Okay. Thank you for your question. And I think I must say thanks to Dr. Nicholas for laying a very good groundwork for me to continue my answers for this. Okay, so usually just a little bit of context. In our setting, almost over about 70% of women with cervical cancer actually present at a late stage. Yeah, and so actually knowing about the signs and symptoms that you must not ignore is really, really important. Okay, so basically the symptoms can be divided into early stage symptoms and advanced stage symptoms. So one of the commonest symptoms that women with cervical cancer present with is bleeding after sexual intercourse. And so you might tend to see some patients come and then they'll be like, oh, they have been seeing some slight blood after sexual intercourse for like months. And then they didn't really think it was that important to come to the hospital until when like it was very bad or very severe. So any bleeding after sexual intercourse is something that you should not ignore. Then usually any abnormal bleeding during your menses, it could be bleeding in between your periods. It could be that the periods are now heavier and longer. It's also a sign that you need to come to the hospital. Now, I must stress the fact that usually, so cervical cancer is not the only condition that can give you bleeding in between your periods or heavy or longer periods. However, it is a symptom, and it's important that when you have such, you come to the hospital and let the doctor evaluate to know, okay, is this potentially cervical cancer or is this something benign? And then also, one of the key features of cervical cancer is that women tend to have vaginal discharge, and this vaginal discharge actually have a specific type of odor, and it's actually quite unbearable. And so once you have any vaginal discharge that has some type of odor, it's important to present to the hospital. Sometimes this vaginal discharge can also come with a tinge of blood. It could be like bright red blood, it could be like altered blood. And another symptom could be that during sexual intercourse, there might be associated pain. Now, usually by the time we see patients, they usually have this and some other advanced symptoms, meaning that this cervical cancer has started spreading to some other organs or some other areas around the cervix. So one of the typical symptoms they present is that they can be having like severe abdominal pain, and then there might be abdominal swelling, there might be swelling in the lower limbs, that's the legs. At this point in time, a lot of women might be coming down with probably they have problems passing stool, or some might even see blood in stools, or probably when they're passing stools, it's quite painful. Quite a number might also come with difficulty passing urine. There might also be blood in urine, or even when they are urinating, it might be painful. And then general cancer symptoms that I think it's not really specific to cervical cancer also is that they tend to be losing quite some weight, and then they're easily tired, there's loss of appetite, you can't really keep anything down. And then when it has gone to distant sites also, especially the lungs, they tend to come with cough or difficulty in breathing. So and a lot of these women, like I said, over about 70% will come with these late stage symptoms. But those earlier symptoms, especially bleeding after sexual intercourse and vaginal discharge with a very strong odor and pain during sexual intercourse, are really key or early features suggestive of cervical cancer that needs warrant someone to come to the hospital for evaluation. Thank you.
Thank you so much. This is really eye-opening because I think a lot of people would not even expect that, oh, cervical cancer would come with things like swelling in the abdomen, swelling in the leg, affect urine, urinary symptoms. And if they did have that symptom, they wouldn't think, oh, I have cervical cancer. So this is why these sessions are super, super important. And I should have asked you this first. I know Dr. Nicholas touched a little bit on the risk factors but from your own, expertise, your own clinical setting, what are the major risk factors for cervical cancer, and which women are at most risk for cervical cancer?
Okay, so I think cervical cancer is one of the cancers that has been well studied. Like its natural history, its progression is like really, really known compared to a lot of other cancers. And just like Dr. Nicholas said, human papillomavirus has been like the main implicating causative factor for cervical cancer because HPV virus causes nearly all cases of cervical cancer, almost about 98 to 99% of cervical cancer usually occurs as a result of persistent human papillomavirus infection. And the thing is that more than 80% of women are going to actually acquire at least one type of high-risk human papillomavirus infection in their lifetime. But the good thing about human papillomavirus also is that about 90% of women will clear this infection over 2 years. Because I know someone might tend to ask, like, okay, so if this human papillomavirus is that common, how come not everybody has cervical cancer? That is because a lot of these human papillomavirus infections are being cleared. But then in about 10% of women, this human papillomavirus will persist. Now, the problem is that when it persists, it can lead to cervical cancer. And usually from the time of infection up to when you can develop cervical cancer takes about 10 to 20 years. So given quite a long period of time for you to be able to screen and identify either early lesion or precancer lesions. Okay. And now I must stress the fact that there are over 150 types of human papillomavirus. Not all have been implicated in cervical cancer and other cancers, but the ones that have been implicated are called high-risk human papillomavirus. Think about 17 of them have been implicated in causing cervical cancer, but the two most commonest ones are human papillomavirus type 16 and type 18 that has been shown to cause about 78% to 79% of cervical cancer cases, while the other high-risk virus cause about 18% of these cases. So once you have a persistent infection over the course of some years, you might have some changes in the cells of the cervix, and then that will give you the precancer lesions that we tend to look out for during screening and all. So most of the other risk factors then are risk factors that either increase your susceptibility of getting this human papillomavirus infection that has been implicated in causing cervical cancer, or it limits your chances of clearing this infection. Like I said earlier, about 90% of women are going to clear this infection, but then some of these risk factors will limit the chances of you clearing this infection. So just like Dr. Nicholas had said earlier, early sexual debut. So because HPV is a sexually transmitted infection, so it just means that once you have attained sexual debut, you are at a risk of getting the human papillomavirus. And usually because younger girls and their cells are still immature, some cells are still immature, are kind of like more susceptible to getting infected with this virus and persistent virus. So when you look at some texts, it's like about some will quote 15 years, but I've seen a lot of texts that are like 18 years usually. So within 15 to 18 years, less than that, there are higher risks of getting cervical cancer if they attain sexual debut before that time. Now, high parity also, when you have women that have given birth multiple times, this is also closely related to like the more sexual exposure, the more parity, the more times you've given birth, the more likely you have had multiple sexual exposure, the more your risk of getting HPV infection and all that. So some lifestyle also increases the risk of you getting cervical cancer when you have multiple sexual partners. That also increases the risk of you getting all different types of HPV infection when you have partners that also have multiple sexual partners. So you might not have multiple sexual partners, but you might not have a partner that probably has multiple sexual partners. So it also increases your risk of getting this HPV infection that can lead to cancer. When with multiple sexual partners or partners with multiple sexual partners, also increase your risk of getting other sexually transmitted infection like chlamydia, HIV infection that limits your risks of your chances of actually clearing the HPV infection. Smoking also have been strongly implicated in limiting the risks of women clearing this HPV infection. Now, also, when you have like weak immune system, let's say like you have a HIV infection, or for some reason you're taking some immunosuppressant drugs, it could be cancer drugs, it could be like some immunosuppressant drugs that are used to treat some conditions. As long as they weaken your immune system, they limit your chances of clearing this infection. So those are kind of the, so generally in all, the risk factors that associated with cervical cancer either increases your chances of getting this HPV infection, or it limits your chances of clearing the infection and increases your chances of this HPV infection persisting in your cervix and then leading to changes in your cells and leading to cervical cancer. Yeah, thank you. Over.
Thank you for your response. So, who should go for cervical cancer screening and how often should they do it?
Okay, so cervical cancer screening is a secondary prevention, yeah, for cervical cancer, because for prevention of cervical cancer, the focus mainly is primary prevention and secondary prevention. And if you remember when I was talking about the natural history of cervical cancer and how it what causes cervical cancer, so it's either you are targeting like, okay, so we try to make sure girls and women don't have this HPV infection, or you try to get that, okay, so even if you have this HPV infection, you try to target to identify if there are any early changes that this HPV infection will cause before it leads to cancer. So that is where screening comes about. So you're trying to identify abnormal cells that are not yet cancer but can lead to cancer as a result of the changes in the HPV infection, so that you can treat them before it leads to cancer. So usually there are different multiple guidelines about who to screen, but generally, universally, a lot of the guidelines states you start screening women from 25 years to 65 years when they have attained sexual debut. Now, there are varying options or screening options that we have. The conventional or the routine one we typically use and that has been used widespread is the cervical smear, commonly known as pap smear. It also has different types. We also have different types of cervical smears, but general cervical smear, all it entails is that you get some scrapings of the cells at the cervix and then test under the microscope to see if there are those abnormal changes. And if there are, then you treat accordingly. Then of recent, we also have the HPV testing. So this HPV testing like goes to identify if you actually have one of those high risk HPV types that increases your risk of getting cervical cancer. And then for low resource settings like ours, because we all know the challenges in our settings, so you might not really a lot of areas, especially rural areas, you might not really have facilities for this pap smear You might not have facilities for HPV testing, and then women might not be able to go to far places to get this done for them. And then you need to get an alternative for them so that we don't like lose these women to like someone that should have had a screening will now not have a screening just because we don't have these other two options. So we have the visual inspection methods, and the most common one is the visual inspection with acetic acid. It's easy to use. It just involves applying acetic acid to the cervix, that's the mouth of the womb, and then you see some abnormal changes. And even a lot different cadres of healthcare workers can do. I know community health extension workers are being taught to apply this and also see these changes, and also apply Lugol's iodine, basically also, and then you don't need a microscope, just with your eyes you can see if there are changes or not. And the beauty about those visual inspection methods is that you can actually see the changes at that point in time, and also offer treatment to these women at that point in time. And you can use it at different levels of health facilities, primary, secondary health facilities, especially primary health facilities that you might not be able to have, you might not have those cervical smears or HPV testing. I must also stress the fact that these visual inspection methods also have been used in a lot of outreaches. You know that before now, most of our screening has been like opportunistic screening. So you see like different organizations, it could be faith-based organization, non-governmental organizations that just go into rural communities, advocate for cervical cancer screening, get women for the screening. And then if you say you want to take a smear and go and test, most often I know you might not get to reach those women again. So a lot of people use the visual inspection method, see if there are any abnormal cells, try to treat it there and then. Now back to the cervical smear and HPV DNA testing that are routinely used. So usually we commence at 25 years up to 65 years. So if you are using the pap smear, you do a pap smear every 3 years. Once you do it, if it's normal, you repeat it every 3 years till 65 years. When you have two negative pap smears as of 65 years, then you can discontinue the screening. However, if you're using the HPV testing, it can be done every 5 years rather than every 3 years. But I must stress the fact that for women with HIV, their screening tends to be more frequent. You remember the risk factors, HIV tends to limit the chances of women clearing this infection. So you want to do it more frequently in HIV positive women compared to the normal population. Now, before now, these are like basically intervals that have been used globally. But just a couple of months, like Nigeria, actually, we released our own national screening guidelines, right? Although it's not yet fully implemented, they are still at advocacy stages, and a lot of facilities haven't like really implemented it. And before now, we didn't really have a structured screening guideline. It was mainly opportunistic screening that we were doing for women. But from this recent guideline that they brought out, so for Nigerians, our guideline is that we want to start. Okay, so let me just give a context. The guideline was actually adopted from the WHO strategies for eliminating cervical cancer by year 2030. And also it put into context the fact that there are challenges in low and middle income countries, and that might limit the kind of screening methods we have and the frequency of screening. So they try to look for avenues to make sure that whatever screening that we are doing is like cost effective and will not lead to like a dropout for women bringing themselves up for screening. So for this current guideline, it's advocated that we start our screening for women at 30 years with HPV testing, and then we do it at 10 years interval. So the idea is that by 2030, about 70% of women should have been screened with a high performance test, that is the HPV testing, by 35 years of age, and also again by 45 years. So by the time you are 50 years, from 30 years to 50 years, it's expected that you must have had two HPV testing of at least 10 years interval. And then once you are 50 years and you have two negative screening that's of 10 years interval, you can discontinue. But we know that a lot of our women like can reach 50 years and they've not had any form of cervical cancer screening. So you might actually see women coming at 50 years for you without any screening. So what do you do for these women? You do not tell them to go back. So you can also offer them this screening at 5 to 10 years interval, and then you can discontinue it when they have two negative screening at 70 years. I must stress the fact that this is a new guideline, and it's not really, it hasn't really been implemented all over the country, because I know for a fact that a lot of facilities do not even have this high performance HPV testing available. So a lot of facilities still use the pap smear. And for some facilities that have the HPV testing, why not? They do it 5 yearly, the pap smear 3 yearly. And in primary health facilities, a lot of people still use the visual inspection method. Even in secondary health facilities, like especially those in rural areas, to use the visual inspection method. So basically, between 5 years and above, you've had you're already sexually active, you avail yourself for screening. Yeah. Thank you. Over. Dr. Nabila?
Thank you, Dr. Hannatu. Thank you for your response. So we screen, but how can we prevent cervical cancer at individual and community levels?
Okay, so thank you for this question. I like the fact that this question was asking for individual and community prevention, because we all collectively have a role to play to prevent cervical cancer. So to show you how cervical cancer is really a border, not just in Nigeria, not just in Sub-Saharan Africa, globally. That is why there's the WHO cervical cancer elimination strategy, right? And then they have this 90-70-90, so that, and their aim is to eliminate cervical cancer from a public health aspect, right? So elimination of cervical cancer, they are trying to reduce the threshold of cervical cancer to at least 4 per 100,000 women. To show you that we have a very long way to go to reach that 4 per 100,000 women. In Africa, as of 2022, according to the global cancer statistics, right, there are some regions in Africa that have as high as 40 women per 100,000 coming down with new cervical cancer cases. So imagine trying to bring it down to 4 in 100,000 women. That means that we all have a role to play. So at individual level, basically, it just means that you need to modify your risks of getting cervical cancer. Basically, like I said earlier, how do you modify your risks of getting cervical cancer? First of all, you have to prevent yourself from getting cervical cancer. From getting HPV infection. So how do you prevent yourself from getting HPV infection? It boils down to the HPV vaccine, right? Now, this HPV vaccine prevents girls, prevents women from actually getting infected with the human papilloma virus. It's highly effective. It has been shown to reduce the risks of reduce the likelihood of getting the HPV, high risk HPV infection, and in the long run, cervical cancer. So at an individual level, you can avail yourself to be vaccinated with the HPV vaccine. And then also, okay, so even if you've not been able to benefit from the HPV vaccine, with or without the HPV vaccine, you can avail yourself for routine screening, cervical cancer screening, like we've already talked about. Then you can also modify your other risk factors, like, okay, trying to delay sexual debut till at least like 18 years and above, and having safe sexual practices. As I must stress that, this human papilloma virus infection, right, you don't necessarily get human papillomavirus infection only by penetrative sexual intercourse. Even skin-to-skin contact can also lead to human papillomavirus infection. So we need to practice safe sexual practice, right? Use of condoms does not totally eliminate human papillomavirus infection, but it has been shown to reduce the chances of risks of transmission. Also trying to stay with one partner, because like you earlier said, multiple sexual partners or even partners with multiple sexual partners increases your risk of getting the human papillomavirus infection. Avoid smoking. Try to maintain a good immune system by eating well, and also by eating well and prevention of other sexually transmitted infection. Now, at a community level, I believe that what we are doing right now, it's a community, that's like what the community, the role of one of the roles that the community needs to play. That's like increasing awareness about cervical cancer body. It might interest you to know that yes, you might think every year we shout cervical cancer left, right, and center, but there are some people that have never even heard of cervical cancer screening, have never even heard of human papilloma virus. Because I might be seeing a patient in clinic, like, okay, so have you done a pap smear before, HPV test? You'll be like, okay, have you heard about cervical cancer screening? And you'll be like, no. So I mean, like creating awareness, health education, advocacy campaign, it's never, we can't say we've done enough. It's a continuous thing. So we'll continue to educate, we'll continue to create awareness as a community. You tell your friends, you tell your sisters, you tell your sisters to tell their friends, you tell your aunties to tell their friends, and all that. So at any point in time, we try to create awareness as a community, right, about cervical cancer. Also, apart from the community awareness, be it like family or community of friends, I feel like another point that we could do collectively is to incorporate this awareness in especially modification of risk factor in school-based health programs. Because I mean, like, once you've had a sexual intercourse, you've already exposed yourself to the risk of getting HPV infection. So it's important that we incorporate like sexuality education in schools, so that in order to let our girls, to let our boys know that, okay, so it's important that these are the risks if you actually have an early sexual debut. These are how you protect yourself against this kind of infections and all that. These are the short-term implications, these are the long-term implications, right? And then also, another role the community can play is making screening easily accessible. I remember when I was asking about like community outreaches and all, and I know like most of the cervical cancer screening, a lot of cervical cancer screening in Nigeria have been done through outreaches. So these are one of the ways that we could do. And most often than not, like these outreaches, people are readily available to help with these outreaches. Sometimes like there are sponsors directly available to like help with resources for these outreaches. Human, like I know, like I might just now like, oh, we have an outreach, I want you to come and help us with cervical cancer screening, and I'm readily happy to do that. So as collectively as a community, we can organize like community outreaches so that these women, especially in rural communities that might not have heard of cervical cancer screening, or they don't even know how to go about like getting screening, can actually attain this screening like at the tip of the like just at their doorstep. Then another thing we can do about this is also preaching the gospel about HPV vaccination, because I mean there are a lot of myths about HPV vaccine. Some will say that, oh, that it causes infertility, is a form of contraception, no. And this one, some people will be like, that this HPV vaccine, it will make our girls promiscuous, or it promotes early sexual debut. So we have to educate our people. We need to create awareness that this vaccine, it's not to promote promiscuity among girls or increase early sexual debut. It is not a form of contraception. It does not cause infertility. I mean, it's safe. It has studies have shown that it's very safe to use. It's effective. The primary aim of this vaccine is just to make sure that our girls and even our boys don't have this HPV infection. And then, so basically, these are what we as a community can do to actually help prevent cervical cancer. Thank you. Over.
Thank you very much, Dr. Hanatu. So for a very, very common organism, that's the HPV, the vaccine really does not get enough PR. It doesn't get enough publicity. And like you said, we can't really say we have done enough. There's always someone who has not heard of cervical cancer or the vaccine for that matter. So who should receive this HPV vaccine? What age? Who is eligible to get it?
Okay, so this HPV vaccine, like I said earlier, it's to prevent HPV infection. So, and it's more effective before a sexual debut. So that's and studies have shown that the target age group for this should be between 9 to 14 years, both girls and boys, to be honest. 9 to 14 years before they have attained any form of sexual debut. Because I mean, even from your first sexual intercourse, you're already exposed to the risk of getting HPV infection. And the idea is to give the vaccine before then, right? So now, but in as much as the target age group is 9 to 14 years, right, we can actually have, there's this concept of catch up up to like 26 years. So even if you've made, you're already more than 14 years, and then you have not been able to have this vaccine beforehand, can actually do a catch-up vaccination up to 26 years of age, right? And this vaccine is available in Nigeria. I mean, there was like widespread, it was incorporated into our national immunization schedule. I know since October 2023, there have been widespread advocacy and rollout. I think the rollout was in 2 phases in different states, and it's officially like in our national immunization schedule. It's available for free in primary healthcare centers. But then this availability for free in primary healthcare center is for girls between the ages of 9 and 14 years. But I mean, if you're more than 14 years, does not mean that you cannot have this vaccine, just that you might not be able to get it for free in those primary healthcare centers because the country has a target age group because it has been shown to be more effective. But I mean, there are other facilities, secondary facilities, private facilities that actually have this vaccine that can be out of pocket for that, right? So now I know probably some people will be wondering that, okay, so what if I'm more than 26 years or I've already had a sexual debut? Will I be able to take this vaccine? Yes, there's a room for that. Yeah, because in as much as like I said, the primary target group, it's more effective at that 9 to 14 years before sexual debut. But then if you've had a sexual debut, you're more than 14 years, you're more than 26 years, and then you've done a HPV test for the specific and types of HPV test, HPV that this vaccine cover, basically 16 and 18, right? And then it's negative, right? You can actually go have the vaccine because at that point in time, you are not infected with those strains of HPV, so you can have the vaccine. Like I said earlier, you will need to pay out of pocket, probably from a private facility or private pharmacy or something. And I must stress that it's not as effective as those target age group, but it actually also has a role to play for you not getting infected with those strains that you don't already have or you are not infected with, even if you've had a sexual debut. Yeah, thank you. Over.
Thank you so much for an impactful session. That's Dr. Hannatu Kachiru, our specialist obstetrician and gynecologist with over 10 years of clinical and public health experience. Reminder that you can send in your questions and we'll attend to them by the end of the session. So without further ado, I'm moving on to Ummi Musa Umar, our public health specialist and radiotherapy specialist. She's also the founder of Call Off Cancer Initiative and U Health Africa. She's a passionate youth advocate that leads cancer prevention and tobacco control efforts in Nigeria while pioneering digital health solutions that expand access to care. Ummi, are you with us?
Yes, I'm here. Good evening.
Good evening. Thank you so much for joining in. Thank you for having us.
It's my pleasure. Thank you so much.
So we'd like to know from your own expertise, what is the role of radiotherapy in the treatment of cervical cancer?
Okay, so radiotherapy, for those that don't know, is using radiation for treatment. There's radiodiagnostics where we use radiation for diagnosis like imaging, CT scans, X-rays, and then there's radiotherapy, which is my specialty, where we use radiation to treat cancer and some benign tumors like keloid, for example. So for our focus today, which is cervical cancer, radiotherapy is a core life-saving treatment. It is either used alone or with chemotherapy, depending on the guidelines of each country. But for us, in my facility, we use it together in a technique we call chemoradiation for locally advanced disease. which is after surgery to reduce the risk of recurrence. So sometimes they do this also for symptom control in other climes, and it works by destroying cancer cells or shrinking the tumors, especially in areas where surgery cannot safely reach generally. So in many women, radiotherapy offers the best chance for cure, particularly when the cancer is diagnosed early to mid stage. It helps so much. And apart from the external beam radiotherapy that we all have known or heard about, there's also the internal beam radiotherapy that we call brachytherapy, where the source is put inside the patient. In the case of cervical cancer, it's inserted through the vaginal canal, and a specified dose of radiation is given in both cases of external beam and internal beam. The doctor prescribes, the medical physicist plans, and we set up and we use radiation to treat. But before the planning, there is also the use of imaging modalities to take images of the affected area, of the area of interest, so that there will be proper planning using advanced imaging like CT or MRI to plan the treatment. Thank you.
Thank you. I think I speak for a lot of us when I say this is the first time we're actually hearing how radiotherapy works. So is it safe, and how do doctors protect healthy organs during treatments?
Okay, so the question about safety of radiation generally, not just radiotherapy. Let me start with radiation, because even for us that use radiation to work, we have heard all sorts of scary things about the fact that radiation causes cancer. So the fact that it is a double-edged sword, it causes cancer and then it's used to treat cancer, is something that has been known to be confusing to people. For us, I remember when I was studying in the medical college, a lot of people, when I tell them that I'm studying radiography, and they'll be like, oh, you people are going to be exposed to so much radiation. It's going to be very risky. Even your children can get abnormalities. There is a lot of I can say misconceptions, because people don't talk about the fact that it can be prevented, and there's protection around using radiation. That is why we are licensed, and that is why we take an oath too during our induction, because you are trained to use this and you are certified in radiation protection for yourself as a professional, for your patient, and for the general public. So there are three arms to it. You're protecting yourself, you're protecting your patient, you're protecting the general public. A patient comes for a CT scan from a consultant, and I see mild cough probably, and then I see that this request is CT scan. As a professional, I can take back the patient and maybe talk to the doctor and see, why are we doing a CT instead of an X-ray? Because we all know that one chest CT scan is equivalent to 150 chest X-rays, and the amount of radiation that the person receives from doing a CT is very high. Even though we still make sure that we only expose the area of interest, but still, radiation is something that, for people that know, is nuclear energy. So people have to be protected from it. So in the case of radiotherapy, yes, part of the things that radiation can cause is cancer, but then I can say it is a bit of a paradox that radiation is also used to treat cancer. Why? Because radiation kills cells. Radiation destroys cells, like I mentioned in the first question. So we use that technique to destroy cancer cells. One thing about normal cells is that they are able to regenerate and recover. Meanwhile, cancerous cells are unable to regenerate and recover. So that is the technique used. So yes, modern radiotherapy is much safer and more precise than in the past, because you cannot compare the linear accelerators we use now and the cobalt 60 that was used in the past, for example. And also, we protect healthy organs by using advanced imaging to plan the treatment and also carefully shaping radiation beams to target only the tumor. As a professional, it's my responsibility to ensure that the area of interest is the place that I expose. Because if a person is not trained, that is why quackery is unacceptable in our kind of profession, because the risk is just too high. A breast patient can come and you lie her down, use the same beam that was planned for her, that was meant to be safe, but then you're projecting the beam to her abdomen, for example. So if you're not trained or you're not careful or you don't know the risks on radiation protection techniques, you could easily be harming the patient rather than doing good. So when we give radiation, we ensure that the benefit outweighs the risk, and we use techniques known as ALARA principles, as low as reasonably achievable. So we know that we're giving the lowest level of radiation possible to achieve the highest level of benefit. So, like I mentioned, we carefully shape the beams to target only the tumor, and we limit exposure to nearby organs like the bladder, bowel, kidneys. Some organs are more radiosensitive than others. Some get more damaged by even little amount of radiation. Some cannot even handle radiation at all. So delivering treatment in controlled doses over several sessions is one way in radiotherapy that we use to make sure that the patient is kept safe and that we reduce the side effects to the barest minimum. And also, patients are closely monitored and side effects are managed early. As a professional, we are trained to understand the symptoms that are to be expected for each part of the body when it's being exposed. For example, if you're doing a head and neck cancer, you know that your beams could be very close to the eyes, to the brain, to the thyroid. And if you're doing the breast, you're careful not to expose the lungs or the heart. And you're doing the, for example, for cervical cancer now that we're talking about, we know that it is just beneath the abdomen. So you have to also be careful of nearby organs that could be irradiated. So yes, I think it's all about professionalism in what we do and putting the patient's safety and also our safety at the center of the work. Thank you so much, and over.
Wow, that was a lot of knowledge and information, and we can see how radiotherapy is, like you called it, a double-edged sword. And we can understand why there's a lot of fear and misconceptions surrounding it. So, for you, what are the most common misconceptions you hear from patients about radiotherapy? Why do women fear it so much?
Okay, for example, I think because we are very conservative people, we find it very hard to accept or embrace new things. And we can say that for radiotherapy, our access to linear accelerators in low and middle income countries is we have very low access. For example, we are in this country of like 250 million people approximately. Ideally, every 1 million population should have one linear accelerator. But we barely have 10 functional linear accelerators at the moment in the country. So we can say that it is grossly inadequate. So you look at that much population and with the number of linear accelerators that we have, and you know that a lot of people, you would even tell them what is a linear accelerator and they don't know. And there's also the fear for big machines, even MRI and CT machines. We struggle with patients that have that fear that this is going to. I remember when I was practicing MRI scans, a lot of people would say that it feels like they're in the grave. So I think that's claustrophobia, fear of enclosed spaces. So most of the machines that we use for radiation, whether diagnosis or treatment, are something similar to that. You see a big machine, rolling around you, and I know it can be scary. So that is one, the fact that we don't see it often. How many states have linear accelerators? You could see an entire region in this country with no linear accelerator, for example. I could say the Northeast, except if Maiduguri comes back, or if before Maiduguri started, the people that have not traveled somewhere to go and sit in accelerators wouldn't even know, except they see it on the internet or on the television. So it's still something that people actually like find strange. Like, what is this big machine? And then they tell them that it treats cancer. Oh my God, that disease that kills. So I think the myths also are communicating in a way. The myths that are attributed to cancer, the fear is also attributed to the treatments, even chemo. So for radiation therapy, we hear things like it causes infertility. But the person that says it causes infertility isn't informed to understand that only if it is used in an unethical way would it, for example, be exposed, would it expose the gonads and cause infertility. Yes, it can, but then there is a continuation to that explanation, which could bring down the fear of radiation. Just know that if you're in in an accredited facility, you are being handled by a licensed professional, then you know that you wouldn't have that fear, because definitely radiation protection is at the core of their practice. And then radiation burns people from the inside, the fact that in Hausa they call it haskeme chutarwa, people think that from the inside it is burning their organs and that they can never recover from it, So a lot of women actually refuse radiation therapy because they feel like, after chemo, this thing is going to fry their organs, So these misconceptions, I think we see a lot of it for patients that come because first of all, when they're sent from the doctor, they come to us in the CT simulation suite, and that's when we try to talk to them and enlighten them. And if they have any questions, we enlighten them on their questions too. And those are the kind of things that they ask. How is it? How does it happen? Some of them will be peeping. They want to see the machine, and then we tell them this is the CT scanner. This is not the machine. We're going to show you the machine before we begin. So another thing is that radiotherapy means death is near, So you're already put under this big machine to help you survive for a little more longer. So death is very close by. I think, yeah, that is generally like the fear attributed to cancer. And I have heard of someone saying that when you give them radiotherapy, they become radioactive themselves and go home and harm their family. So you see, that is somewhat true when we talk about nuclear medicine, because yes, that can happen with nuclear medicine when radiopharmaceuticals are injected into the patient. And in that case, the patient is being kept and monitored in the facility. In National Hospital, that is what they do. So, but then, like I say, people take one sentence out of the truth and use it to create the misconceptions. So some ways that we use to address these things are making sure that we enlighten the people. And also part of advocacy, even through our NGOs, is to also teach people about radiotherapy. Last year was the first year that World Radiotherapy Awareness Day started. And I think it was one of the best things that have happened to radiotherapy awareness, honestly, globally. Even though it is not very much into this part of the world, but if you're online, you must have, especially in the medical groups, WhatsApp groups and social media, you must have seen that it was commemorated all across the world last year. I think it was 6th of September. Yes. So, and it is a big organization that are trying to now come into Africa and create the much needed awareness around radiotherapy to show that radiotherapy actually saves lives, not put lives at risk. I have been privileged to be a part of the conception of the idea during the London Global Cancer Week in 2024. That was when the spotlight events happened, and we had something like a discussion and something like what do you call it when people are asked to give ideas and the best idea is being taken, about the date of the preferred date for the global day around the globe. So 6th September was chosen, 6th or 7th September, I'm not sure. So yeah, so that was how it started. And I think it was a very good idea, because a lot of people get to understand, even in the high income countries, actually, not just here in this part of the world. So if even those parts of the world need awareness about radiotherapy, that should tell us that, in fact, we need to double up on our own awareness to make people understand that it does not make patients radioactive, and to know that the side effects are usually temporary and they are manageable. And also for many women to be able to complete their treatment and return to normal living. There's hardly some side effect that you say that this is permanent, and even though that scares people the more, but we cannot say that every kind of side effect is temporary, but most of the known side effects that happen are temporary. So fear often also comes from late presentation, misinformation, and stigma, because when people present late, that's when they are most scared because they know that the disease is advanced. So it's usually not the treatment itself, because from the beginning, it is that fear that keeps people at home. They don't come and seek treatment early. So I think education, counseling are just as important as the treatment. We cannot just blindly shut down patients and say, no, just let me do this for you. We don't have time for questions and answers. That counseling is very, very important as the treatment. Thank you.
Thank you so much for your response. Those are a lot of misconceptions. I have a feeling you do a lot of counseling. And speaking about late presentation, how does that affect the success of radiotherapy?
Okay, so yes, generally we know the effects of late presentation when it comes to cancer management. That is why that I think there's no slogan that have been circulated more than early detection is key. Even though I heard from the previous speaker, one thing that I like, I think he or she mentioned early action. So it's not just early detection, because early detection does not usually end up being early treatment. It can be detected early, but then there could still be late presentation to begin treatment. So, but then early detection is one of the biggest challenges in cervical cancer care too. When it's detected late, treatment becomes more complex. For example, we see patients that come that are bleeding heavily for cervical cancer, and before they begin the the normal sessions for radiotherapy, we have to do the hemostatic radiotherapy, for us to stop the bleeding. One of the things that radiation can do is to alleviate pain or stop bleeding, So that makes the treatment becomes more complex. And also, we all know that when cancer is advanced, the cure rates are lower. Early cancers that are detected early are easier to treat, are cheaper to treat. So early detection is not just does not just save lives, it is also easier and also cheaper for the patient, because we know a lot of we know how much financial toxicity we have. Not everyone gets access to cancer health fund. Not all cancers even can be sponsored through the cancer health fund, and also not everyone even has access to complex treatments like radiotherapy. And even the side effects when it comes to radiotherapy or other treatments of cancer like chemo, side effects may be more pronounced if the patient disease is already advanced, because with advancement of the disease, the patient is sicker, for example, is more sick than if it's detected early. There are early detections that you see that walk in and out, and if they don't tell you, you wouldn't even know that they are sick, for example. And also early detection through screening like HPV testing or VIA, it dramatically improves treatment success, because the patient just goes for screening and then it's seen. We are not waiting for symptoms to occur. One of the reasons that we call cervical cancer the silent killer is because of how some of the symptoms mimic some other I don't want to say normal things that women see abnormal, but it's one of the things that are quite common, like toilet infection, and other things that women usually see and end up treating at home, or using over-the-counter drugs. So the fact that it mimics those things could make it very hard for a woman to know that this is serious and we need to go to the hospital. So that is another thing that advocacy is important. And part of advocacy is actually teaching women the symptoms of cervical cancer, just like the previous speaker listed out. So it's very, very important. It increases the treatment success, and it also increases the survival rate and also the quality of life. So this is why it's just like the public health angle of things. Screening, referral, and follow-up systems are as critical as the radiotherapy treatment that we are giving patients. Thank you. Over.
Thank you so much. And for the final question, to wrap up your session, can women live normal lives after radiotherapy for cervical cancer?
Oh, yes, absolutely. Absolutely. I would like to share this very heartwarming story of a woman that we treated last year. She's quite elderly and she was a nurse, so she's a retired nurse. And I think it hit her very hard because of the fact that she was a healthcare worker. And the first day that she came from the doctor to book for her radiotherapy, so book for CT simulation first, and she started telling me the story about how she was getting this abdominal pain that is persistent, and she didn't think much of it. She said that she only screened once in her life and that her husband has died like over 10 years ago. So she usually, in the recent years, when people go for screening, she used to say, I don't even have a husband. They say it's sexually transmitted, you know? So you see, there is a knowledge gap there because we all know that cervical cancer sometimes could take decades for the HPV infection to turn into precancerous lesions and before it turns to full-blown cervical cancer. So she told me, and we communicate with patients, we educate them the more so they go back to their communities and also become advocates. So to cut the long story short, she got her radiotherapy and she got her brachy. And I think it was in December that she sent me a video of herself dancing in her church. And she made a lot of videos and sent to me, making testimonies and saying that she's healthy now. She sent a video of her in a party dancing, and she was telling me that I think she turned 70 or something. So I think the fact that she came and she was elderly and she was scared and she was thinking that maybe she was reckless and that was why it happened to her makes her feel like maybe it's the end. And the fact that she didn't even have a husband to support her. So it was a very it was a sad journey from the beginning because I think she suffered a lot during chemo, the side effects, even during radiotherapy, and the financial toxicity too. She wasn't under CHF or NHIS doesn't do much for cancer patients. So, but at the long run, she got better. She was sending pictures. So that's the testament that yes, women do, after completing treatment, they can return to work, their family life, their community roles. Long-term effects can vary, but most of them are manageable with follow-up. And usually they don't tell patients, "You just go, you are cured." She told me that she's coming in a March for her follow-up. So yes, of course, they'll be followed up, and but then they live normal lives. Emotional recovery and social support are also very important, for that normal life to actually be normal because part of the side effects is not just physical or something that we see in the body, it's also in the mind. So that's one thing that also needs recovery. We know that that is the psychosocial aspect of something that I think is quite weak in our health system, but it's very, very important. And sometimes it's not the conventional see a therapist or see a counselor. Even the support system that patients have at home really help them to recover. The mindset that that they carry with them also helps so much. And survivorship care is not just the follow-up. Apart from the regular follow-up visits, there's also knowledge of how to manage delayed side effects. And psychosocial support also includes sexual health support because we see very, very young people now coming up with cervical cancer. I think just this week or yesterday, a very young patient, 24 years of age, she says she's turning 25 this year. And I was so stunned and I was asking her about her early life. And because I was trying to make sense of it, she's just 6 years into her marriage. Even though sex is not marriage, we all know, but still, for a young woman like that, it makes you think and wonder. So of course, she's her husband came with her. He's also young, so she's going to need a whole lot of sexual health support because in our kind of conservative environment, those are things that people don't like to talk about. We were talking yesterday with my colleagues in the brachytherapy that a lot of patients come after radiotherapy and there's adhesion of the cervical canal because even when we tell them, if you have a husband, please, you can be having intercourse, sorry, you can be having intercourse to help so that it will prevent adhesion. That's one of the side effects of radiotherapy to that part of the body, to the groin. So, but then a lot of them feel like, no, as I'm battling through this disease, how can I do that? And we give options. We have dilators that you can use. You don't have to. I was even telling my colleague yesterday that we should just stop mentioning intercourse because it seems like you're insensitive. Like I'm going through this and you're telling me to go and have, So we have dilators. I was even telling them we could have NGOs come and donate these dilators. Let's just be giving patients, we can just look the size that they need and give them. So that it could help them. Some of our matrons and nurses are very experienced. They advise them to use candles and all. So these are all part of the support that they need because they could go home now and that adhesion has happened. And they start having problem with their spouse. Maybe that's the only support that they have, the husband, and that becomes a huge problem that affects their recovery. So basically, what I can say is that radiotherapy is not something to fear. It is a powerful tool. It saves lives. The real enemy is late detection, misinformation, and the silence. The silence that we have to discourage because we know that our culture encourages it, but it's not good when it comes to healthcare in the healthcare setting. So when women are informed, they are supported, and they are treated early, cervical cancer can be prevented, can be treated, and they can survive it. Thank you so much, and over.
Thank you so much. That was powerful. That was inspiring. So that was Ummi Musa Umar, our radiotherapy specialist and public health specialist, founder of Call of Cancer Initiative. Thank you so much. I do have a question for all of our speakers, sort of like a cross discussion. So from your different specialties, what is the biggest reason women still present late with cervical cancer in our environment, and how can we change this? So Ummi, you can go on since you spoke last.
Okay. I think in my perspective, I think now I'm not talking as a radiotherapy specialist. I'm talking as a public health person and the work that I do at Call of Cancer Initiative. I feel like honestly, before I used to think it was fear, but over time, I think it's the lack of the financial burden that comes with the treatment, honestly, because a lot of people that say, no, I'm scared, let me go and do the traditional treatment, or maybe let me go and do fasting and prayer, it will go away, it's not my portion. I think if they have the money and they know that they can actually be able to go to hospital and pay for cure to get better for cancer, they would go. They would go because I think there's a lot of improvement when it comes to enlightenment about the importance of treatment and also the importance of treating early when it comes to cancer. But a lot of people know that they don't have the support. The financial toxicity is real. Families get bankrupt when one person gets cancer and they would treat. So there's discouragement that because of me and my life, I had a patient once that came to me. Her husband was to be given palliative radiotherapy, and I gave them the bill. And she took him to the car and she came back to me and asked that we just have a little, assets remaining for his children. Do you think we should squander it and try this? Or do you think we should just leave it to God? Because what if he still goes? Because we know he might not even survive it. So one, there's lack of hope because maybe there's lack of trust in the health system. We don't blame them. We are getting better, but then we are still not there. And then also the biggest problem is the funds, honestly. So that's my perspective. Thank you.
Thank you, Umi. And I agree. I do agree. A lot of times there's a huge chunk that um do not seek care because of financial constraints. However, there's always that portion that is just in denial. Like even for, should I say smaller? I wouldn't call them smaller, but maybe less financially um
Table.
yes. Something like hypertension, for example, or diabetes, like it's manageable, it's lifelong, but it's manageable. And even when you tell them, oh my, you can actually get drugs here for free because this is a lifelong condition, and normally you're supposed to get support for that from the government, or we just give free drugs for diabetes or hypertension. There's always that portion that are in denial. They'll tell you, no, I do not have this, or I will not take drugs for this, or like you said, they'll just pray it away. So definitely there's also that portion that are just in denial. Dr. Hanax, what do you have to add? Would you agree?
Yes, I'll agree with what was said, but I also feel like it's multifactorial, right? Because, okay, so another perspective I think I will draw on is based on like my own experience now in gynecology clinic, right? So, like when we're talking about the late presentation, also, apart from the fact that like at the very first point in time, these women will even come for you to even think that they have cervical cancer or even diagnose cervical cancer. At this point in time, they don't even know they like have cancer, talk more of like thinking about treatment and all that. Firstly, like a lot of women don't even have an idea that like these symptoms are something to be that are bothersome or something that they need to come to the hospital. So, like I said when I was discussing the symptoms, right? You might see someone will tell you that they have been bleeding after sexual intercourse, or they have been having heavy menses, or they have been having one or two for like months, like almost a year, you understand? And like they didn't think it was that abnormal for them to come to the hospital to be seen. So when obviously like these symptoms are like very, very bothersome, and by then, like obviously by the time you are first seeing them, you understand, maybe you're seeing these women at like stage 2B, or you're seeing them at stage 3 or something like that. You get, so by the time you are seeing a woman coming to meet me, like coming to the gynae clinic, and you're seeing a woman in stage 1, it's like, how do I put it now? It's like a rarity kind of, because most of these women, by the time they come at late stages, and like they have been having symptoms for a while, but either they didn't think it was significant enough to come to the hospital, or even as health workers, I must say that we need to have like a strong high index of suspicion, because now the other side of it is that like probably they've been going to some other facilities. It could be like primary healthcare facility or secondary healthcare facility. And then just because they've been having discharge, they've been treated with a lot of antibiotics. And I must say, like a lot of health workers, I don't know, it's like we're really scared of, I won't say scared of, but a lot of health workers, like non-gynaes, are reluctant to do like vaginal examinations. They get, so someone will come and say like they have vaginal discharge, and then all you're thinking of is like probably this person has a cervicitis or a vaginitis, and then you now see like these women have been treated and treated and treated with antibiotics. Meanwhile, just a vaginal examination will have seen like an abnormal cervix, even if you don't know what it is. But like when you see an abnormal cervix, you're like, okay, yeah, I think I need to send this person to the gynae. Yeah. So I think this also contributes to our late presentation. Thank you. Over.
That's definitely true. There's just so many factors in play. Dr. Nicholas, do you have anything to add? Why do you think women present late? Dr. Nicholas, are you here with us?
Yes, I'm here. One of the reasons why women present late is religious belief, sometimes cultural belief. I've seen people who are so deep into their faith, believing that God is going to take care of everything. And, they come, sometimes some of them will come to the hospital, and then maybe one will advise them, go and pray. They stay in the church for long, and then when they come back, it's already late. There's nothing you can do. And I've seen individuals or females, women who were advised not to come to the hospital because they were told that when they are injected, the situation will get worse. At the end of it, you see them coming to the hospital, at the point of death. At that point, you will not do anything. So you see, cultural beliefs and religious belief also play a role in the late presentation to the hospital. Thank you.
Thank you so much. And that is why I think across almost every sector now, if you're trying to bridge a gap in anything, we tend to include religious leaders nowadays because they have a lot of influence. They have a lot of impact on the way people think, people feel, their ideologies, and such. Thank you so much, everyone. So I would like to acknowledge the presence of Dr. Hannatu Ayuba. She's the founder to Tele Oncology Hub and Cancer Consciousness Initiative. Dr. Hannatu, thank you so much for joining us. Thank you for being here with us. Thank you for the support. Do you have any contribution to our session today?
Thank you very much. It has been a wonderful session listening to all the speakers. You have all done great. We're very proud of all the works you're all in your different ways to strengthen the health system. Cervical cancer is a nightmare in the management, the supportive care, the survivorship challenges. They are so much, and we are happy that we are getting people that are interested in managing cervical cancer. The multidisciplinary team management of cervical cancer gives better outcomes. So this is a clarion call to all our colleagues, all other healthcare workers, for all the support they are giving in the management of cervical cancer patients to continue to give the best. Thank you very much. Thank you, all our dear partners. Thank you.
Thank you so much, Dr. Hannatu. Thank you for the work that you do and the work that you put in. So we're going to be taking questions from the audience. Let me just check in. So we have a question that was received via email. It says, a woman with suspected cancer of the cervix had pap smear, awaiting results. The husband requested for intercourse. So I think this user is trying to know what is the next step, what is the ideal thing to do when a woman who is being suspected with cancer of the cervix, she had a pap smear, she's awaiting results. However, cancer of the cervix is suspected, and the husband requested for intercourse. I'll throw this question to Dr. Hannatu.
Okay, and thank you for this question. So let me make a correction so that we are not confused as to the role of pap smear. So pap smear, when you are suspecting cervical cancer, you don't do a pap smear. You understand? Rather, I would rather do a examination and biopsy to confirm cervical cancer. Because I mean, when I examine a woman and I can see some features of cervical cancer and I'm suspecting cervical cancer, I will do an examination under anesthesia and I will do a biopsy and confirm, right? Now, a pap smear, cervical cancer screening, is for women that you are not suspecting cervical cancer. Do you understand? These are normal women that are going about their normal activities, but you are trying to screen for pre-cancer lesions, like pre-cancer state. So you might find some abnormal cells because a lot of these women that have these pre-cancer lesions, will not have any symptom. They're just going about their daily life. Like I said, because you don't want to wait for it to reach cancer, then you come. So so that's why the question is like a little bit I don't know the English word to put it. Yeah, by the way. So, but in general, usually, so for a woman that has had pap smear, that means you are not suspecting cervical cancer. She has had pap smear, you are waiting results. I mean, like nothing stops you from having your sexual intercourse. However, when you're preparing for pap smear, right, we try to abstain from like sexual intercourse just before the pap smear and all that, because there are so many things like that could affect the integrity of the cells of the results that you're going to put. But I mean, after when you're waiting for your results, you don't have any symptoms, you don't have any complaint. I don't think there's anything that stops you from having sexual intercourse, right? But then if you are suspecting cervical cancer, we don't do a pap smear. We try to confirm that this woman has cervical cancer, right? So I don't know if that makes my answer clear.
Yes, Dr. Hannatu, thank you so much. I hope the user is listening and hopefully this answers your question. So from the chat box here, Mustafa Aliyu explained further on radiation therapy. Thank you so much. And Abdul Malik Aliyu says, is there any provision by the government for extension of awareness of cervical cancer to remote areas, IDP, internally displaced persons, and Sangaya of females? Is there any governmental and non-governmental organization that provides assistance for cervical cancer? I think I'm going to merge these questions and throw them to Umi. So from the work that you have done with your NGO, have you heard of any governmental or non-governmental organizations that provides assistance to cervical cancer patients or extends awareness to the less privileged communities?
Okay, yes, so absolutely, yes. There's the Nigerian Institute for Cancer Research and Treatment, the NICRAT, is working with sub-regional governments, state governments to for awareness, for treatment support. And I think yes, there is awareness because for example, you can't say that the government will organize an outreach specifically in a village or something like that. But when they are doing anything like that, they have the CSOs that they trust and they work with. We have, I'm sure we have done some work with NECRAT in the past. Some campaigns were initiated by our own NGOs, and some are things that they are doing and they call on NGOs to support in one way or the other. So I think advocacy takes different approaches. When you're talking about outreaches to rural areas, is usually something that non-governmental organizations are known to do. For example, during October, we see a lot of breast cancer awareness and outreaches across the country, even across the whole world, because it's known for breast cancer awareness. And like this month of January is the month for cervical cancer awareness, and you see all over social media, advocacy doesn't just mean you have to go to the place. For example, last World Cancer Day, my NGO with some survivors were at the BBC Hausa because we are thinking that people in the rural settings that are not privileged to have the internet, they usually are very good with listening to the radio, especially in local dialects. So we were there and we talked about it. Survivors shared their experiences, and that I'm sure would go a long way because the estimated number of people that listen to the radio, especially in rural communities, runs in millions. So those are ways that you either go to the community or you use radio jingles talked in the radio or even in TV. There are local dialect TV channels that are very eager to have advocates come to them or NGOs. We have gone to a lot of them that air across the country. And I know that 2 years back, one of the early campaigns that we did was the Ruga outreach, where we took our outreaches to the Ruga settlements. We know that those rural communities like the Ruga are always at the edge of healthcare service delivery because they are very mobile. They don't stay in one place. So they are totally living outside of civilization. I think it's safe to say that they're living outside of civilization. So they need a lot of education and awareness. So we did that, and I think that's very, very impactful. And I've seen NGOs that go to IDP camps. Yes, they go to IDP camps. They do awareness campaigns. They do free screening, even though our people usually run away from these things, because I know of NGOs that go to rural communities and they're practically begging people to come and get screened. And it all boils down to the sensitization, this World Cancer Day too, it's coming up next week. And a lot of organizations, like we are also partnering with another NGO and the National Primary Healthcare to do cervical cancer screening and awareness for cervical and HPV vaccination. We're going to screen the women and vaccinate the girls, and also create awareness in the villages. We chose 2 states, FCT and 1 other state, between February and March. So we do a lot of these things, and other NGOs too do a lot of, especially the bigger NGOs that have the resources that could cover more communities. So yes, that happens. And as for the second question, any governmental and non-governmental organization that provides assistance to cervical cancer patients. So yes, cervical cancer is covered under the Cancer Health Fund, CHF. So patients apply and they get approval, and they get a wallet that would be credited, and they can use it for different aspects of their cervical cancer treatment. And NHIS is there, but it's not everything that NHIS covers. It covers 50% of some of diagnostic investigations that are done, and some aspect of the treatment too. I knew that 50% we used to cover for our radiotherapy patients until last year, when it was revised and it was no longer feasible for the patients because the price was even higher than when they pay cash. So these things are, I think, one of the bottlenecks that we see. Universal health coverage cannot be overemphasized. We are far from it, but I think the Cancer Health Fund is doing so much to help patients, and we hope that more patients will get access to it, and then more cancers will be covered. For now, it's only breast, cervical, and prostate cancers that are covered. So we are hoping that more cancers like colorectal and childhood cancers will be included too. And also there are other organizations that we work with, some that we can do. We do donations for cancer patients. We do fundraising. We did that last year in October for our NGO. And recently, just 2 weeks ago, we did a fundraising too for a cervical cancer patient that needed to complete her chemo. So yes, these things happen. I think it's just for you to meet the right NGOs that have the resources. And for us, if you come with things that are beyond what we can afford, we have bigger NGOs that we are collaborating with, like the Medicaid Cancer Foundation. There's another foundation in Lagos that supports radiotherapy treatment for any cancer. So yes, there are a lot of them. I think you can reach out to any of the NGOs, especially through the Nigerian Cancer Society. And yes, you can get access to those NGOs and how they work. Thank you so much, and over.
Thank you for your response. Over to you, Dr. Nicholas. Let's have a take-home message from you. So what is the single most important message every woman should remember today?
Well, the most important message is that, cervical cancer is a sexually transmitted disease and is preventable. The burden is much here in the low-income countries. There's need for us to put all hands on deck, to educate our people about the cervical cancer itself, the viruses, and then the preventive measures, be it behavior modification, the vaccines we talk about, and then how it presents. Early presentation is very important, especially most of our people are not educated. They are not aware of this. We need to tell them. for those who are privileged, like I had a sister who presented with just abnormal bleeding. She was 63. By the time we just took her for for checkup investigation, lo and behold, it was cancer. But the good thing is that it was an early cancer. She's doing very well now because she was treated in National Hospital. She did very well. So, but the thing is that the privilege she had is that I'm a doctor. I was able to pick up these symptoms, and then she was attended to on time. But many patients do not have that privilege, so it's a problem. So we need to put hands together, all health workers, be it the gynecologists, radiotherapists, oncologists, nurses, medical laboratory technicians, scientists, including the pathologists. And, sometimes the type of cancer also influence, treatment. So the responses are not the same. I know we didn't talk about the morphology much. It can be squamous or an adenocarcinoma. So their responses are not the same. I think those who have adenocarcinoma tend to do a bit better than the squamous cell. So all of them have different morphologies. Like the squamous, there are up to 10 morphological types. The adenocarcinomas, there are up to, I think, 11 morphological types. So adequate diagnosis is important, So when the pathologists make the diagnosis, it should be accurate enough to tell the oncologist that this is what it is, so that the patient will be treated, adequately. Thank you.
Thank you so much, sir. So to our listeners, let's remember to get screened. Let's remember to get vaccinated. If you're a male, tell the women in your lives, encourage them to get screened, vaccinated, and also encourage early hospital presentation. Thank you so much, everyone. Let's remember we have another session tomorrow, our Ask My E-Doctor session, and another beneficial Friday health session next week. So thank you to our guest speakers in person of Musa Umar. Thank you, Dr. Hanatsu Kachuru. Thank you, Dr. Kwapmi Nicholas. Thank you to our partners, the Tele Oncology Hub, Cancer Consciousness Initiative, the Call of Cancer Initiative. Thank you, everyone, for joining in. The team members, organizers, my e-doctor. Thank you, everyone.
Thank you very much.
Thank you.
All
Thank you
right.
for having us.
Thank you.
Bye.
Have a good night, everyone.
All right. Good night. Thank you so much. Good night.
Thank you. Thank you for having us.